Hi guys, it's Danielle. Today I'm going to be presenting some research on a topic very near and dear to my heart as a labor and delivery nurse. I'm going to be sharing some vital information about decreasing postpartum hemorrhage. The topics that I'm going to focus on are utilizing oxytocin alone or oxytocin and some other agent, whether it be pharmacological or non-pharmacological, to help prevent bleeding after delivery. According to a study conducted in 2015, oxytocin was labeled as the gold standard when it comes to preventing and stopping postpartum hemorrhage. So no matter what other tools we're utilizing, oxytocin has been labeled as the number one, the best, the way to go standard, and it is currently what we utilize in practice in labor and delivery. So a little information. Postpartum hemorrhage is classified as a blood loss equal to or more than 500 milliliters following a vaginal delivery, or 1,000 milliliters following a C-section or cesarean delivery in the first 24 hours after birth. It is the leading cause of maternal mortality, and the World Health Organization statistics suggest that 60% of maternal deaths in developing countries are due to postpartum hemorrhage, accounting for more than 100,000 maternal deaths per year. That was in 2007. A study conducted in 2016 estimated that 140,000 maternal deaths per year are caused by postpartum hemorrhage. That was a practice bulletin published by the American College of Obstetricians and Gynecologists. 140,000 seems like a really large number, so let's put it in perspective. Every year, one woman dies every 4 minutes from postpartum hemorrhage. That means that by the end of my presentation, approximately 4 to 5 women will have died from postpartum hemorrhage, a very real issue. This should be easily fixed. As a labor and delivery nurse, I experience postpartum hemorrhage very often, but I had one patient specifically that really pushed me to want to conduct more research. She had made it an hour and a half through her recovery with normal bleeding. When I went in to assess her for the final time, she started hemorrhaging. Within 5 minutes, I had 2 doctors in the room, 8 nurses, a CRNA, an anesthesiologist, and 3 technicians. Within 3 more minutes, we had a life and death situation on our hands and sprinted to the operating room for an emergency D&C. This patient lost over 3,000 milliliters of blood. She lived, but I can specifically remember looking in her eyes and seeing death flash before me. In that moment, I knew that postpartum hemorrhage was an issue that needs to be corrected immediately. So why does it matter? A story like that should convince anyone that this is an issue that needs to be taken care of. But death should never have to be on the mind of a new mother. She should be able to enjoy her new baby safely and without fear. This is important to me because as a nurse, I hold her life in my hands. Once that doctor leaves the room, it's on me to take care of that mom and that baby. When something goes wrong, it's on me to point it out to the doctor. It's on me to find someone to help me. It's on me to take care of her. And this impacts the public because at some point in life, almost every individual will experience birth in some aspect, whether it be a mom, a sister, a cousin, whoever. Whether you hear about it on the news, some way, somehow, birth is going to impact you. The healthcare system needs to be utilizing the most up-to-date and preventative measures to prevent excessive bleeding. And as a woman, I think I deserve the right to know that I can carry a child, deliver that child, and recover safely, and have the satisfaction of knowing that my doctor is knowledgeable and has researched the most recent evidence and will be utilizing it on me and my care. So the statement that I'm wanting to conduct research on is for postpartum women in a hospital setting, is oxytocin combined with another agent better than oxytocin alone in preventing postpartum hemorrhage in the first 24 hours? After consulting with our instructor, I decided to go with the 24-hour time period instead of the first 2-hour time period because bleeding does occur after those first 2 hours and it is still heavy in the first 24 hours. So when conducting my research, it doesn't matter what project I'm doing, the first thing I do is I always make sure that I have full text and peer-reviewed articles. That way I know I am getting the most up-to-date information and it is the best quality work available to me. The first place I always go is also the SBU library databases. I check CINAHL and Medline, and most of the time, that gives me enough information and enough articles to conduct my research. However, for this article and this information, it did not. So I consulted Cochrane, Medscape, and the Archives of Gynecology and Obstetrics. I utilized these databases because I knew I would have the most up-to-date information on the topic at hand, and I also wanted to utilize the best evidence-based practice for research in my study. Contrary to popular belief, there was not a lot of articles specifically related to postpartum hemorrhage and oxytocin infusion or injection. But there were a lot of articles related to postpartum hemorrhage and causes of it. So I broadened my research and that I would conduct information about that. So I searched postpartum, pregnancy and childbirth, and postpartum hemorrhage / retained placenta. Retaining your placenta is one of the top reasons for postpartum hemorrhage, alongside having an atonic uterus, which basically means that the uterus does not contract after delivery. The Boolean operators that I utilized were and, or, and the. I used and more than anything, and utilizing those words, I got over 1,000 articles, which seems like a lot. However, it wasn't a lot. I know that sounds odd, but utilizing those Boolean operators and other terms, I have gotten over hundreds of thousands of articles before. So 1,000 articles did not seem like a lot. But I wanted the most recent information and the best information. So I limited my years to 2013 to the present, which means all of my articles are within 4 years old. To me, that is very recent information and very utilizable. Specifically, I searched oxytocin instead of oxytocin intramuscular or oxytocin intravenous. I wanted information with oxytocin in every form. That way I could get the most information and see what doctors are utilizing other than in Mercy Hospital. When I originally researched the guideline website, there were only 2 articles on postpartum hemorrhage. 2 articles is extremely small and is not enough information to conduct a research project. So I had to broaden my terms and then shrink them down again. All the articles that I reviewed, but the third, were similar in the way that they utilized at least one pharmacologic intervention to prevent postpartum hemorrhage. The third article simply talked about the incidence of postpartum hemorrhage related to an atonic uterus. I'll discuss that a little bit more later. So the first article utilized a subcutaneous injection of Methergin and an IV injection or infusion of oxytocin. So in labor and delivery at Mercy Hospital, the typical postpartum oxytocin infusion is 20 milliunits in 1,000 milliliters of lactated Ringer's solution. Immediately after delivery of the placenta, we run the 20 milliunits of oxytocin on gravity, and we run it wide open, full speed, as fast as it can go in. Because the faster that we get that oxytocin to those receptors in the uterus, the faster that it's going to automatically start clamping down and going back to pre-baby size instead of being at 40 weeks stretch gestational age. Sometimes, however, oxytocin is not alone and the mom still continues to bleed. So we will use a subcutaneous injection of Methergin, which also is going to stimulate the uterus to contract. We use 0.2 milligrams of Methergin. The second article that I utilized focused on whether or not an IM or intramuscular injection of oxytocin worked better than an intravenous infusion. The only difference that this article proved is that an IV oxytocin infusion has more immediate results. It's going to work a little bit faster. However, it doesn't prove to work as long. The intramuscular infusion takes longer to work in the immediate period. However, it lasts longer. That was the only difference this article noted in the 2 administrations. However, the sample size was not large enough, and they specifically said that more research needs to be done to have a more accurate article to show effectiveness of the route. There was no statistical difference in blood loss utilizing these 2. It was very similar. The only difference was how fast the IV worked versus the intramuscular. So referencing that third article I talked about a second ago, it focused on the increasing incidence of atonic postpartum hemorrhage. Atonic postpartum hemorrhage references the uterus staying stretched at however many weeks gestation the baby was delivered. So imagine that your uterus is 37 weeks large. That is much larger than the size of a normal uterus. A normal uterus is about the size of a pear. Think about all the pregnant women that you see. Their belly is a lot bigger than a pear. So when the uterus stays that large, it doesn't stop bleeding. The placenta tears away, the baby is gone, and there's still that high amount of blood flow to the uterus. We have to have the uterus clamping back down to pre-baby size to prevent hemorrhage. The study was not completely conclusive, and it showed that a larger and more diverse population was needed to have an adequate representation of atonic postpartum hemorrhage. The study was conducted only on Irish women. We need to conduct studies in the United States, in Canada, in Mexico, in developed countries, in underdeveloped countries. One study alone of one population is not good enough to make a generalization about the general public of pregnant women. The fourth article combined 2 pharmacologic agents to prevent postpartum hemorrhage, and this article was actually one of my favorites and one that I had never considered before. So the 4th study showed that utilizing prophylactic administration of sublingual misoprostol, or Cytotec, and the active management of third stage of labor had similar results as the gold standard oxytocin use. So before delivery of the placenta, in this study, a tablet of Cytotec was placed under the patient's tongue, and utilizing that along with the oxytocin infusion seemed to work very adequately. However, they once again said that more studies needed to be conducted to have more accurate information to make better generalizations. So the 5th article focused on preventing postpartum hemorrhage with prophylactic oxytocin. So basically what that means is that before the placenta delivers, we would administer oxytocin IV or IM to see whether that prevented postpartum hemorrhage. Once again, this article stated that it was not a large enough sample size to have conclusive information. The research that I conducted of the 5 articles proved that there is definitely a need for more research to be done concerning the best method in preventing postpartum hemorrhage. Many articles talked about what we're doing is good, but it needs to be better. The current methods we're using are working, but 1 woman dies every 4 minutes from postpartum hemorrhage. There needs to be something better implemented across the obstetrics world. So my conclusion is that research alone has not proven that there is a need for a practice change due to lack of evidence presented on the subject. There is a need for a change, but there has not been enough research conducted to prove what method is the best, what method works better than others, whether utilizing only the gold standard oxytocin is better than oxytocin and Methergin, or oxytocin and Cytotec, or an IM oxytocin and then an intravenous oxytocin. Current statistics concerning the mortality rate of pregnant mothers who suffer from PPH and die should be evidence enough to encourage research to be done to find the most precise and effective way to prevent postpartum hemorrhage. In the time that I took to tell you about the research on postpartum hemorrhage, potentially 4 women have died from a problem that should be preventable. Bleeding out should not have to be a concern of a brand new mom. She has enough on her plate. And as healthcare professionals, we need to utilize the best information for these moms because they are a very vulnerable population and they look to us for their specific care and to see that their lives are taken care of. I hope that this presentation has given you information about postpartum hemorrhage and has spiked a fire in you to find something in your field of study to be as passionate about as I am concerning postpartum hemorrhage and making sure that my moms and babies stay alive. Thanks.